So good afternoon. My name is John Savransky, and I have the privilege of introducing this session and moderating this session of late breakers that might affect clinical practice. We will have two parts to this. The first part is that the seven people to my left will be presenting simultaneously released journal articles. And then around 5 o'clock, we will have a special section where Dr. Peng from the Wuhan province will talk a little bit about his experience treating patients with coronavirus COVID-19, and we'll have two U.S. experts also speak briefly. So again, the first part, 7 people, and then at 5 o'clock, some new information on coronavirus. The first speaker will be Dr. Stephen Simpson, talking about trajectories of sepsis.
Hi, good afternoon, and thank you for allowing us to present our data on the trajectories into, through, and out of sepsis over the 7-year period from 2012 to 2018. My disclosures are these. Most important among them is that the views I'm presenting are those of the authors and not necessarily those of the U.S. government. I'll be presenting data from a triad of papers that were presented or published on Friday the 14th. And I'll be presenting data from the Trajectories of Sepsis paper and from the Methods, Models, and Forecasts of Sepsis paper. These were published in Critical Care Medicine. I need not tell this audience that sepsis is a tremendous healthcare burden, both in the United States and across the world. This was a healthcare quality improvement study carried out conjointly between BARDA, the Biomedical Advanced Research and Development Authority, and CMS, the Centers for Medicaid and Medicare Services, using CMS's Data Link project and focusing on Medicare patients. The objectives of these studies were to explore patient sepsis level trajectories before, during, and after hospitalization, and to model the influence of clinical features on short and long-term outcomes of sepsis. We used Medicare claims data that were analyzed from January 2012 through December of 2018 in the largest inpatient epidemiologic study yet reported. Dr. Kim Sharetta reported yesterday on the burdens of sepsis in terms of lives and finances. We're going to take a smaller subset of that data, 736,000 patients that had a unique sepsis visit in calendar year 2017 and no sepsis admission during calendar year 2016. We will compare those patients to 6.8 million patients who had a non-sepsis admission in 2017 and no sepsis admission during 2018. In this slide and in all subsequent slides, sepsis patients will be represented by dark blue and non-sepsis patients by light gray. We will look at a clean year going in, 1 week before the inpatient stay, 1 week and 6 months after the inpatient stay for these patients. On the lead-in to admission, we asked the question, can we use chronic conditions to predict who is going to be septic? These are the top chronic conditions in both the sepsis and the non-sepsis group. Notably, the top 5 conditions are exactly the same condition in exactly the same order. Additionally, among the next 5 chronic conditions down, 3 of the 5 are the same. In essence, one cannot tell the difference. We then looked at conditions that sepsis patients expressed more commonly than non-sepsis to see if they could be discriminatory. 2 things were important. One is that sepsis patients did have a history of a previous sepsis diagnosis and about 3.5 times as likely as a non-sepsis patient, and sepsis patients were more commonly had ulcers by about 2 times. The remainder of these conditions were present in fewer than 20% of the septic patients. We then looked whether sepsis patients had seen a provider in the week previous to their admission, what the rate of those provider encounters might be, when those encounters occurred, and where those encounters occurred. Sepsis patients saw a provider in the week prior to their admission over 50% of the time. Sepsis again in dark blue, non-sepsis in gray. Sepsis encounters were slightly more prevalent than non-sepsis, seeing a provider in the week before, and there was a slight declination in this over the period of study. When were the patients seen in that week? Going from right to left, from 7 days to 1 day before admission, there was a gradual increase up until the day before, and there was a tremendous spike 1 day before admission, both in the sepsis patients and in the non-sepsis patients. There is no discernible difference. Where did these encounters occur? They could occur in the outpatient setting. They could occur in nursing facilities. The odds ratio for a sepsis patient being seen in the outpatient setting compared with a non-sepsis patient is 0.74. The odds ratio of a sepsis patient being seen in a nursing facility versus a non-sepsis patient is 3.25. However, the large number of non-sepsis patient admissions obscures this difference, so that would be difficult to see in a prospective fashion. In summary, on the incoming trajectory, we can't differentiate sepsis from non-sepsis in the week before admission, and there is no discernible difference in either the number or the type of outpatient visit. For the post-sepsis trajectory, we asked, can we predict via modeling longer-term outcome in sepsis? We hope to do this with a simple or parsimonious model. First, let me show you that 30% of sepsis patients only 30% of sepsis patients are discharged directly to home with no further assistance. The data I'm showing you are obtained from a web-based application available at Critical Care Medicine. The links to this application are available in all 3 articles, and all of the data backing up these papers is available for perusal of any interested party. This slide we call our sanity check slide. The sanity check because we asked, do our models predict the raw numbers and do they make sense? The answer in both cases is yes. Non-sepsis admissions have the lowest mortality. Increasing levels of severity of sepsis have higher mortalities. Septic shock has the highest mortality at 38%. Focus on this slide on the top 2 bars. We ask the question, does developing sepsis in the hospital make a difference? And the answer to that is yes. Hospital-acquired sepsis confers a double the risk of likelihood of an early death compared with present on admission. We also ask the question, do cancers make a difference? Major cancers we define here as hematologic malignancies, lung cancers, and other metastatic cancers. Cancer increases the mortality of even the non-sepsis admissions, but the take-home point here is if you have a cancer and you get septic and septic shock, your mortality is above 50%. This slide shows the 1 week, 6-month, and 3-year mortality of sepsis among the various severities of sepsis. The key take-home point here is mortality is high even in the lowest severity of sepsis at approximately 60% at 3 years. It is decreasing in all severities of sepsis across the study period. And the question, why will we do our modeling at 6 months? The answer to that is, of all the deaths that occur within 3 years of the sepsis admission, approximately half of them have occurred by 6 months. Where are patients 6 months after discharge? Following a sepsis admission, just over half are in their family home, compared to just under 80% of non-sepsis admissions. In 6 months, 1/3 of sepsis patients have died, compared with 13% of non-sepsis admissions. Roughly 1.5 times the number of sepsis patients will be in a nursing home in 6 months. Now, what happens if you are ill enough to be discharged to a Sniff, skilled nursing facility, rather than directly to home? In 6 months, you are under half likely to be at home, but your likelihood of being in a nursing home is tripled. Age affects the odds ratio for mortality at 6 months. Each decade adds additional risk. And sex. Gentlemen, I apologize, but being male confers an odds ratio of 1.16 compared with being female. In summary, post-discharge, having a sepsis hospitalization is associated with a markedly different post-hospital trajectory. Only about a third of sepsis patients go home with no additional services. Only half are home at 6 months post-discharge, and an initial trip to a sniff worsens the trajectory. How bad is that trajectory worsened? Here's one example. Having one episode of septic shock confers an odds of mortality at 6 months that exceeds that of being admitted with metastatic cancer. Our overall conclusions are that we cannot predict sepsis versus not sepsis admissions based on these data. Sepsis markedly worsens the outcomes and the quality of life, even in the mildest cases, but we are left with one question. It is unclear to us, based on our data, whether acute sepsis is a marker for an already declining health status or whether sepsis itself causes the decline in health status. Thank you very much. Please, for further information, visit one of these websites. Thank you to our co-authors, and thank you for allowing us to present.
So we have time for perhaps one question if people want to step up to the microphone.
So very nice presentation, Dr. Simpson. Let me ask this question from you as a leader at HHS. If people with heart attacks were dying at such rate, there'll be outrage in the country. Why is there not an outrage across all the medical society and medical professions with these results?
Why is there air? I'm sorry, I have wondered myself for many years, why is there not more outrage on this topic? Literally approximately 1,000 people a day die from sepsis, which exceeds a whole lot of other conditions. I'm sorry, I don't have an answer. It's a philosophical question, but I do appreciate the comment.
So the article that you just heard was simultaneously published in Critical Care Medicine. Our next article, which will be or is published in simultaneously in Pediatric Critical Care Medicine, will be presented by Dr. Alison Nair on the clinical characteristics, major morbidity and mortality in trauma-related pediatric acute respiratory distress syndrome.
Hello, so my name is Alison Nair. I'm a pediatric intensivist at the University of California in San Francisco, and I'm really honored to be here today to talk to you about the clinical characteristics, major morbidity and mortality in trauma-related pediatric acute respiratory distress syndrome. So here are my and my fellow co-authors' disclosures and funding. Traumatic injuries are a prevalent cause of morbidity and mortality in children. Specifically, they account for more than 45% of all deaths in pediatric patients. That's more potential life years lost than due to sepsis, SIDS, and cancer combined. In those that survive, ongoing disability affects approximately 50% of these patients. 8 million pediatric patients are injured severely enough to require hospital care each year, and the financial burden is significant, estimated at $14 billion in lifetime medical spending and $66 billion in present and future work loss. Acute respiratory distress syndrome is a significant complication following trauma. In adult trauma-related ARDS, we see a wide range of incidences with a median of 8.4%. I've listed a few important associated factors here, and you can see that the mortality also has a pretty wide range, up to 60%. In general, we think of these patients as doing better than patients with ARDS from other causes, but worse than patients who have just injury alone. Despite the importance in the adult population, there's very little literature to describe this entity in our pediatric patients. There have been only a couple of studies to look at this, and they've all been helpful in starting the conversation, but have a few important limitations, including that they were looked at retrospective data collection. Some of them looked at billing codes to define ARDS. they've used adult definitions to define pediatric ARDS, and there's been an overall focus on mortality as an outcome. What we know so far is that the incidence is up to 4.2%. I've listed a few associated factors, although these haven't been agreed upon in the current studies. And the mortality is significant, so up to 34%. So with that in mind, our goal was to describe the presence, characteristics, associated morbidities, and mortality in trauma-related pediatric ARDS in a large US cohort over a 10-year period. So we turned to Benioff Children's Hospital, Oakland, which is our local American College of Surgeons verified Level 1 trauma center. It serves most of Northern California, and through the trauma center, we have a trauma registry that prospectively identifies all patients presenting. We were able to identify patients between 2006 and 2015. We included patients with a presenting diagnosis of or related to traumatic injury, with subsequent admission as an inpatient to our hospital, and with a PaO2 and chest imaging within 4 hours of each other and within 7 days of the initial trauma. We excluded patients who were greater than 18 years of age, so not children, and who were transferred to another hospital within 7 days of the initial injury because we couldn't reliably follow their clinical course. We define pediatric ARDS by the Pediatric Acute Lung Injury Consensus Conference definition, so specifically acute onset within 7 days of the trauma, hypoxia demonstrated by a P to F ratio of less than 300 or an OI of greater than 4, chest imaging with a new pulmonary infiltrate consistent with parenchymal disease, and respiratory findings that were not explained by cardiac failure or fluid overload. Our primary outcome was in-hospital mortality, but we also looked at neuroprogressive multiple organ dysfunction syndrome as defined by Ppe and other morbidities. We used univariate and bivariate analyses as well as multivariable logistic regression. We set an alpha of 0.05 as a cutoff for statistical significance and used the Bonferroni correction for multiple comparisons. So we were able to identify over 7,000 patients presenting in our 10-year study period. 6,725 patients did not meet inclusion criteria, so that's most of the patients. 65% of these patients did not meet inclusion criteria because they did not have a PaO2. That left us with 657 admitted patients with complete laboratory data and imaging data. 11 of these patients went on to meet exclusion criteria. 8 of them were adults, and 3 were transferred to a different hospital. So ultimately, we had 646 included in our analysis. We identified 59 patients, or 9%, with trauma-related pediatric ARDS by our definition, and the remaining 91% of patients did not have trauma-related pediatric ARDS. So when looking at demographic characteristics between the two groups, what we saw was that there was no difference in age, sex, race, or ethnicity between the two groups. In terms of injury characteristics, patients with trauma-related pediatric ARDS were less likely to have injury due to falls, were more likely to have injury due to non-accidental trauma, and they also had a higher median injury severity score. So that's shown at the bottom, 25 compared to 9. Another sort of interesting thing that we saw was that in patients with the most severe injury, so that's an injury severity score of greater than or equal to 30, the incidence of trauma-related pediatric ARDS was 55.9%. So this affects many of our most severely injured patients. This shows some associated factors that we've seen in adult studies. And what you can see here is that patients with trauma-related pediatric ARDS, which are shown in the dark blue, had a higher percentage of severe injury and traumatic brain injury when compared to those without trauma-related pediatric ARDS, shown in the light blue. In terms of organ dysfunction, patients with trauma-related pediatric ARDS had a higher incidence. It's actually a very high incidence, so 86.4%. So really most of these patients had this sort of global organ dysfunction. This is compared to 10.4% of patients without pediatric ARDS, so they had 8 times the organ dysfunction. Age, injury severity, and trauma-related pediatric ARDS were all found to be independent statistical predictors of new or progressive multiple organ dysfunction syndrome. And these patients also experienced greater morbidities in addition to organ dysfunction, including length of hospitalization, fewer PICU-free days at day 28, fewer ventilator-free days at day 28 as well. There was no difference in readmission between the two groups. In terms of mortality, this was also higher in patients with trauma-related pediatric ARDS, 18.3% compared to 3.1%. So they had 5 times the mortality. This graph shows percent mortality across different injury severity score categories. So 0 to 14 is mild injury, 15 to 29 is moderate injury, and 30 to 75 is severe injury. So we see a couple of things here. First, when looking within injury severity categories, patients with trauma-related pediatric ARDS had higher mortality in the mild and moderate, but not in the severe injury categories. When looking across injury severity categories, you see that patients with trauma-related pediatric ARDS had the same mortality regardless of injury severity. However, those without trauma-related pediatric ARDS had increasing mortality with increasing injury severity. And finally, in our logistic regression, we saw age and injury severity, but not trauma-related pediatric ARDS were independent statistical predictors of mortality. So in conclusion, trauma-related pediatric ARDS occurs in 9% of trauma patients and 55% of the most severely injured patients. It occurs at a higher rate in children with traumatic brain injury or severe injury. It was associated with 8 times the development of organ dysfunction and 5 times the mortality. And it was also an independent statistical predictor of organ dysfunction. A few strengths to note with this study include that this was a relatively large sample size, especially for a pediatric study, that we were able to use prospectively identified trauma registry data. We also verified that data in the medical record. We used a pediatric-specific definition of ARDS, and we were able to focus on organ dysfunction in addition to mortality. A few limitations that will lead us into future directions. So first, this cohort that we analyzed was actually a very small percentage of people presenting with trauma in general. These are likely the sickest patients, so we don't really have a sense of those patients who are maybe are a little bit less sick or maybe have more mild respiratory failure. In addition, we were not able to look at certain biologic and clinical variables from the registry or from the medical record. So for example, we wanted to look at saturation as well as non-invasive respiratory support to augment our definition of pediatric ARDS, and we weren't able to get those from either of those sources. So this really speaks to the importance of prospective evaluation in this patient population. We hope to focus on delineation of drivers in the development of trauma-related pediatric ARDS, identification of key biologic and clinical determinants, and a refined understanding of how these determinants impact outcomes. Ultimately, we want to develop pediatric-specific diagnostic decision support and targeted therapeutic strategies to help improve outcomes in our patients. So with that, I'd like to thank you all for your attention. I'd like to thank SCCM and the Critical Care Congress and PCCM. Heidi and Mitch were my co-authors and have been very instrumental in helping mentor me. I have some other amazing mentors listed, and there's my funding and institutional support. Thank you.
So we again have time for a single question.
So first of all, congratulations on being selected to present and on a very, very nice presentation. There's a school of thought that ARDS is an iatrogenic disorder, and the 2 big implicated factors would be fluid administration and tidal volumes on the ventilator. Do you have any information about those and whether or not they contributed?
Yeah, that's a really important question. We unfortunately were not able to look at volume resuscitation and tidal volumes on the ventilator from these 2 sources. So I think this really, again, speaks to the importance of having really targeted prospective evaluation of this entity. Thank you.
So our next speaker is Dr. Scott Weiss, who will be talking about identification of pediatric sepsis for epidemiologic surveillance using electronic clinical data. And this too will be found in pediatric critical care medicine.
Thank you very much, and thank you to the editorial board of Pediatric Critical Care Medicine for the opportunity to present this study. Oop. There we go. Thank you. So here are my disclosures, none of which are directly relevant to what I'm going to present today. So the most common strategy used to measure the epidemiology of sepsis involves applying ICD-9 and 10 codes to large data sets. Unfortunately, depending on the strategy used and the combination of codes selected, you can get considerable variability in your estimate of both incidence and mortality, shown here for adult sepsis, as well as for pediatric sepsis. In 2017, Chanu Ri and colleagues at Harvard and with the CDC Prevention Epicenters program similarly found that using different strategies of ICD-9 codes, there were differences in both incidence and mortality for adult sepsis. But they went on to use direct clinical data abstracted from the electronic health record to show that they could identify an incidence and mortality that was in between the two most commonly used ICD-based coding strategies. And they went on to validate this algorithm against manual chart review. However, a similar algorithm to detect cases of pediatric sepsis using clinical data direct from the electronic health record did not exist. So we sought to develop a computational phenotype that would allow us to objectively, efficiently, and reliably identify pediatric sepsis cases using routine clinical data, and then apply that computational phenotype to study longitudinal trends in pediatric sepsis epidemiology. We conducted a retrospective observational study at a single academic children's hospital using all ED and inpatient encounters over an 8-year period, excluding patients hospitalized in the cardiac and neonatal ICU who have very specific physiology and likely need a specified algorithm that's different from more general sepsis. The exposure were sepsis episodes that we identified using our algorithm that we derived and validated over the course of this study. And we compared them to a reference standard that was identified as suspected sepsis cases, which were flagged by a quality improvement alert that was embedded within our electronic health record, which we then manually adjudicated each of those suspected sepsis cases for the presence of severe sepsis or septic shock based on 2005 pediatric sepsis definitions. So we specifically sought to identify cases of sepsis that were defined as infection plus severe organ dysfunction, which models the sepsis 3 definition. And we sought to identify only those with confirmed rather than suspected sepsis. And we specifically only utilized data variables that were thought to be routinely collected clinical data that would be accessible in a wide range of electronic health records from both academic and community children's hospitals in order to optimize generalizability of our algorithm. And so to model infection, we looked for blood culture orders or evidence of collection, or because many children are transferred from community hospitals to referral centers, transfer from an external healthcare facility, plus treatment with antibiotics for at least 4 consecutive days, approximate to the time of the blood culture or transfer, or if the patient died or was discharged to hospice before day 4. The first antibiotic must be new in that it wasn't previously administered in the prior 7 days, which was relevant for hospital-acquired sepsis, and must be parenterally administered. But the antibiotic could vary over the course of those 4 days. We chose 4 days because 2 days is commonly used to rule out sepsis, and we were worried a third day would potentially, if people were slightly delayed in stopping antibiotics in those cases. So that's how we selected 4 days, which would indicate some confidence at the level of clinician that they were at least treating a bacterial infection. For organ dysfunction, we turned to sepsis 3, which requires an increase in SOFA score of at least 2 points, which indicates moderate dysfunction in one organ system or mild dysfunction in 2 or more organ systems. So for pediatrics, the best validated scoring system for organ dysfunction is the PLOD2 system, and there's also been published a pediatric modification of the adult SOFA score. So we utilized variables and cut points from those scores, which have been previously validated, and we're able to identify criteria that would indicate moderate dysfunction in at least one organ system within 2 days of blood culture or transfer. Through a several-month period of several iterations, we ultimately settled on 7 criteria to define dysfunction in 4 organ systems, and these are listed here. We did not include neurologic dysfunction because we could not identify a consistent variable within the electronic health record that would consistently and reliably identify the presence of neurologic dysfunction. In addition, although many children with sepsis do have hepatic dysfunction, that it is very rare, if ever, the single organ dysfunction defining problem that causes the child to be labeled as having sepsis, although it often accompanies other organ system dysfunctions. And so ultimately it was excluded because it did not add to the sensitivity of this algorithm. So for our analysis, we did standard test characteristics with sensitivity and specificity on a 10-month derivation cohort and a temporally separate 7-month validation cohort, and then looked at mortality and incidence using Poisson and logistic regression controlled for variables likely to influence changes in sepsis epidemiology over time. So over the course of the entire study period, we evaluated over 800,000 hospital encounters. You can see the patient characteristics from the 10-month derivation and 7-month validation periods were very similar to the overall study cohort. For the derivation period, there were over 93,000 hospital encounters, from which 1,065 cases of suspected sepsis were flagged by our QI alert. We did a chart review on all of those and confirmed sepsis in 187 patients. When we applied our algorithm, we were able to find a sensitivity of 78 and 76%. In our validation cohort, we had a similar sensitivity and specificity. And this compared favorably to the adult study by Rhee published in JAMA a few years ago, with a slightly higher sensitivity and a slightly lower specificity. When we looked at where our algorithm disagreed with our reference standard, we investigated all false negatives. So these were cases in which our algorithm failed to identify sepsis when our chart review said they were septic. And the majority of these were in situations where the patient received less than 4 days of qualifying antibiotics, and this was largely viral sepsis. None of these patients died, and ultimately we were okay with missing these patients, since it's very rare to have a mortality from viral sepsis in kids without a secondary bacterial infection. For false positives, again, these are patients in which our algorithm suggested sepsis, but our chart review said they were not septic. And this was primarily due to differences between our algorithm, which was based on sepsis 3, and our reference standard, which was based on the 2005 definitions, which require the presence of either shock or 2 organ system dysfunctions. And so single organ, this moderate dysfunction in a single organ system was included in our algorithm as having sepsis, and we were okay with that because we feel like it approximates a more contemporary definition of sepsis 3. We then applied this algorithm to the entire 8-year study cohort, and we were able to show in the blue line that there was a slight increase in sepsis incidence among all ED and inpatient encounters, and a significant increase in the orange line in the adjusted incident rate ratio of sepsis incidence among all inpatients. Mortality, however, was stable at around 6.5% over the entire time period without a significant increase. However, with the doubling of incidence, this meant that twice the number of children were dying of sepsis each year at our institution. We then, for face validity, looked at whether the number of organ dysfunction criteria was associated with a stepwise increase in mortality, which is what we anticipated. And in fact, you can see that in the orange bar. And so that suggested that patients who had more organ dysfunction criteria based on our algorithm were more likely to have mortality, which was what we anticipated. And then we looked at the different levels of organ dysfunction and how they related to the level of mortality. And there were 3 specific criteria that were associated with the highest risk of mortality, including use of vasoactives, elevated lactate, and kidney dysfunction. Again, all consistent with prior literature of risk factors for mortality in children with sepsis. So again, supporting the validity of our algorithm. Finally, we asked whether or not a change in the utilization of lactate, which was included as a measure of cardiovascular dysfunction, contributed at all to the rise in incidence, because we've been emphasizing over the years to use lactate more and more in these children. And there was no increase in use of, or in the number of patients who were identified either only because of elevated lactate in the orange line, or as lactate included as one of several organ dysfunction criteria in the blue line. So limitations are that this algorithm excludes viral sepsis. However, it should pick up bacterial secondary infections, which is the high-risk group for viral sepsis in children. We excluded cardiac and neonatal intensive care patients who have unique physiology and likely need a dedicated algorithm. We had no measure of hepatic and neurologic dysfunction. The hepatic dysfunction doesn't bother me because it didn't add much to the algorithm. The neurologic dysfunction, I think, is a problem, but was not able to be, we could not find a variable to identify this reliably in the electronic health record. We had the incongruent reference standard in that we tried to model sepsis 3, but compared that to the older pediatric definitions. This was used for retrospective case identification and cannot be applied for early recognition of pediatric sepsis. And this was done at a single institution with generalizability that's yet unproven. So in conclusion, we were able to develop a computational phenotype that could objectively, efficiently, and reliably identify pediatric sepsis using routine electronic clinical data. And using this algorithm, at least at a single institution, showed that there was an increased incidence with stable mortality. And for the first time, we think this was really able to be free from bias introduced by variability in either diagnosis and claims-based coding practices. Next steps are to validate this algorithm in a multi-center fashion and compare them directly to claims data, and then ultimately to apply this algorithm for the epidemiological surveillance of pediatric sepsis, hopefully across the country. I'd like to acknowledge our collaborators, in particular Fran Balamuth, who was my partner on this work, and thank you very much. Appreciate the opportunity to present.
So thank you. We additionally have time for a single question. So in the absence of, you are using this or plan to use it for epidemiologic reasons, but it seems as though you could potentially use this for other things, identifying patients perhaps.
Yeah, I think for research studies, I think this is great, but because we require 4 days of consecutive antibiotics, there's a slight delay. So I don't think it's not applicable for early recognition for clinical purposes, but certainly has potential other applications besides epidemiology, in particular identification for research studies, quality improvement as well.
So our fourth speaker will be presenting an article that is simultaneously appearing in JAMA on the effect of intravenous interferon beta-1a on death and days free from mechanical ventilation among patients with a moderate to severe ARDS, a randomized clinical trial. Dr. Jeffrey Bellingham.
Thanks very much. I'm delighted to be here. And as you heard, presenting the result of the INTEREST trial, which is a multi-center study of interferon impact in moderate or severe ARDS. Disclosures, the trial was funded significantly by a major grant from the EU, and it was also, the study sponsor was Farron Pharmaceuticals. Myself and Marco Ranieri were the two PIs, and you can see the steering committee there representing each of the 8 EU countries. EU because Britain was part of the EU at that stage. So the background story is that in the muscles, ATP is fundamental. It makes muscles work. But in the extracellular fluid, ATP is pro-inflammatory. The body knows that and tries to get rid of it by dephosphorylating the ATP down to adenosine, which is anti-inflammatory. And it does that through the action of 2 enzymes, CD39, which is constitutive, and CD73, which is expression is increased by the action of interferon, and it can be shed. So here we have the normal body situation with lots of CD73 expressed, lots of adenosine being made anti-inflammatory, and that keeps a non-inflammatory environment, and we believe contributes to lack of lung leak. And interferon is one of the agents endogenously or exogenously that helps protect that position. In the inflamed situation, CD73 is shed, and in the absence of CD73, you have no adenosine, lots of ATP in extracellular fluid, and we believe that to be part and parcel of the lung leak you see in ARDS. So ARDS shedding a CD73 and no current treatment for that. We undertook a phase 1-2 trial across a number of centers in the UK, and quite a remarkable outcome, which was really a dose-finding and safety study where we found a mortality of 8% in the interferon beta treated patients and 32% in our control group. This was published in Lancet and led to the workup for our phase 3 INTRA study. The design of the study was a double-blind, placebo, randomized control study across 8 countries in Europe, 47 sites. We wanted to get the drug in early, within 48 hours, which is when we thought the lung leak was paramount, because later you get all the inflammatory and cell destructive processes that we didn't think this was necessarily going to be part of. Primary endpoint was a combined composite of survival and ventilator-free days at day 28, and multiple logical secondary endpoints, mortality, 28, 60, 90, etc. Safety being studied, and you can see the powering of the study there. To be sure that we had ARDS, we used 2 medical monitors who are on call 24/7, so huge thanks to the 2 of them, Nicola and Peter. And any site wanting to recruit a patient had to match the X-ray from their patient with one of a number of X-rays provided by the medical monitor, only some of which had ARDS. And that helped us focus down on ARDS in the population and recruiting the right patients. As you heard, we're very proud that our study is being published in JAMA today, and I'm going to present the results here. The consort diagram, we obviously screened a large number of patients with ARDS, and a significant number were excluded. The majority of exclusions were patients with ARDS diagnosed more than 48 hours before, a number with ECMO, and another group who had significant exclusion factors, home ventilation, severe heart failure, etc. We got down to a number here, 301, who were randomized, and you can see equal randomization then into the 2 groups, and the number here that we were able to assess out at 90 days. The demographics, I don't want to spend too long here, very similar between the interferon-treated and the placebo-treated group. You can see that pneumonia was the most common cause of ARDS, sepsis the second most common cause. The patients were reasonably sick with a significant Apache score, SOFA score, and the number with severe ARDS similar in the 2 groups. It was worth noting that the number on corticosteroids at the onset of the study was quite significant, with about 31 and nearly 40% in those 2 groups. It was a safety study as well as an outcome study, and the safety groups between placebo and interferon for the most common treatment emergent adverse events, no significant difference. I note the slight increase in pyrexia here. That's what you would expect with interferon beta being administered. And it's just worth keeping an eye on rhabdomyolysis. Whether this 5 was a random chance event or not, we'll need to keep a watch on. Otherwise, no obvious difference in terms of most common safety events, and similarly, no obvious difference in terms of serious safety adverse events. If you give interferon, how do you know it's doing anything? People don't go blue and turn pink with spots or whatever, but you can measure a biomarker, and MXA is the best biomarker, and you can see MXA increasing and peaking here at the end of our 6-day treatment course compared to our placebo. So we were comfortable that the interferon was working. We were measuring CD73, recognizing that this is soluble CD73, so we don't know what's happening in the lung, and we saw an increase in soluble CD73 in our interferon-treated patients, but there was a similar increase in our placebo-treated group. So whether this meant there was an endogenous interferon or other reasons for shedding, including just the major injury, we have yet to find out. 28-day mortality, no difference between either the interferon or the placebo-treated group. It's worth noting a relatively low mortality with both groups. When you look out at 360 days, again, no difference in the mortality between the 2 groups. They were remarkably consistent over that time. And when you look at ventilator-free days, again, no real difference in ventilator-free days between the 2 groups. We were interested in the impact of the corticosteroids. We had far more corticosteroids being administered to our patient group than in our Lancet respiratory paper. And we did retrospective analysis of the impact of corticosteroids on the outcome, and we noted that glucocorticoids at baseline tended to favor the placebo group versus no glucocorticoids at baseline, possibly a slight impact favoring interferon. We've done further analysis on that, and that will be subject of a subsequent paper, which will be of real interest. So in conclusion, we can say that for moderate or severe ARDS, intravenous interferon beta for 6 days compared with placebo resulted in no significant difference in the composite score of death and number of ventilator-free days over 28 days, and nor did it in any other of our significant secondary outcomes. There were no major safety concerns with the use of interferon beta. The results, therefore, do not support the use of interferon beta in the management of ARDS. We have to say that that's where there's part of an SOP that includes the use of steroids. Concomitant use of glucocorticoids may have interacted with results. Glucocorticoids use was associated with mortality both in interferon and the placebo group when adjusted for Apache. And therefore, we think further studies may be warranted for interferon beta as a treatment for ARDS without concomitant use of glucocorticoids. And I make that point because care is needed in the treatment of clinical conditions associated with interferon beta activation. So if you consider viral-induced ARDS as is happening right now, your own body is producing significant interferon beta, and the use of glucocorticoids is not recommended there by the WHO, and I think we should be considering that as a different group of ARDS versus non-viral, non-interferon endogenous production, and that may need further look at. I'd like to acknowledge a large number of study sites and a very large number of workers on what was a fascinating study to do, and I thank you all for your kind attention. Thank you very much.
So we have time for a question.
Any explanation for the relatively low mortality in your group, in both groups?
I'd love to know. We opened up we try to keep our exclusions very, very limited. We were allowed all forms of cancer. We had hematological malignancies. We did exclude liver disorder. We did exclude people with significant pre-existing lung injury, but nothing very different to other studies. So we don't really know why the mortality was so much lower and lower than our baseline Lancet study.
Our fifth manuscript, the effect of using a machine learning-derived algorithm versus standard care on intraoperative hypotension during elective non-cardiac surgery, or the HYPE randomized clinical trial, will also be released in JAMA by Dr. Vembira.
Thank you for the introduction, and I would like to thank JAMA and the Society of Critical Care Medicine for the honor to present our results here today. My name is Marije Wijnbergen. I'm an MD from the Amsterdam University Medical Center in the Netherlands, and I will present the results of the HYPE trial. This was a randomized clinical trial where we assessed the ability of a machine-derived early warning system to actually reduce hypertension during surgery. And as of today, published in JAMA. As a research group, we received funding from Edwards. The problem, intraoperative hypertension, it occurs frequently. 87% of patients have at least one hypertensive event during surgery. So why is this relevant? This is relevant because it's associated with postoperative outcomes. This has been shown in both cohort studies and also in one RCT published by Fouché. And if you summarize those studies, you see that it's associated with cardiac outcomes, such as myocardial injury and myocardial infarction, with renal outcomes, such as Acute, and even with mortality. So therefore, the perioperative consensus statement of 2019 concludes we should try to maintain a MAP above the 60-70 threshold during surgery. And they also state that injury is a function of both the time spent in hypertension, but as well the depth, so the severity of hypertension. And current treatment of hypertension is reactive. Before we conducted the RCT, we did a short prospective observational study, and we saw that the average time from onset of hypertension till first treatment is 1 minute and 30 seconds. So actually that adds up. A potential solution would be to change this treatment from reactive to proactive. However, we as doctors are not always able to predict hypertension in a timely manner. But luckily, a machine learning algorithm is able to do so. And the machine learning algorithm we used in this study is solely based on the arterial waveform. It's developed by a company with input from intensivists and anesthesiologists. And it provides you with a value ranging from 0 to 100. So, for example, 85 means there's an 85% chance of hypertension to occur in the following minutes. This algorithm has been internally and externally validated, showing good results 5 minutes prior to hypertension. But as we all know, prediction is not the same as prevention. In order to actually reduce hypertension, the prediction needs to be followed by a correct and timely intervention. So therefore, we performed the HYPE trial, an RCT, where we wanted to see if it actually reduces hypertension, measured at both the time and the depth. For this study, all adult patients planned to undergo elective non-cardiac surgery requiring general anesthesia and with an indication for an arterial line were eligible. And we excluded patients in which the treating doctor wanted to maintain a different MAP, so a MAP higher or lower than 65. And it was also not allowed to use a goal-directed fluid tip protocol or any other protocol. And the other exclusion criteria are based on the early warning system. It's not validated in those patient populations. So what did we do? In the intervention group, we connected the study monitor with the early warning system, and we provided the treating doctor with a diagnostic guidance and treatment flowchart created by the study team to enable timely diagnosis of the underlying cause of the impending hypertension. And in the control group, we had standard care, and we connected the study monitor, but we blinded the early warning system. And this is a diagnostic guidance and treatment flowchart. So in this study, we asked the anesthesiologist to act when the chance was higher than 85. And then based on hemodynamic variables visible on the study screen, such as stroke volume variation and systemic vascular resistance, the treating doctor was able to diagnose the underlying cause of the impending hypertension. And important to note, the treating doctor was free to choose the dosage of the drug he or she wanted to administer. Our primary outcome was the time-weighted average in hypertension. So, as I mentioned before, this is a combined endpoint. You take the time in hypertension and the depth of hypertension, and you divide it by the total study time to be able to compare patients. And one of the potential negative effects we thought of using such an algorithm could be overtreatment. So therefore, as secondary endpoints, we assessed hypertension and the dose of medication used. We randomized 68 patients, and 8 of those patients had to be excluded after randomization but before surgery because the treating doctor wanted to maintain a different MAP threshold, or because the surgery was cancelled, or in one case because of technical failure of the device. So we ended up with 31 patients in the intervention group and 29 in the control group. So as you can see, the median age of our population was 64, and the majority of patients were gastrointestinal surgery. And I want to the exciting part, I think. what we saw is that the time-weighted average in hypertension was significantly lower in the intervention group. But as time-weighted average is a relatively new endpoint and a little bit hard to grasp, we also noted the total time and other hypertension endpoints. And what we saw is that the median time spent in hypertension in the control group was 33 minutes compared to 8 minutes in the intervention group, which I think is an astounding difference. And actually, all hypertension endpoints were significantly different between the two groups. And then onto hypertension, so the assessment of overtreatment. We saw no difference between the two groups for all hypertension outcomes. And lastly, the dose of medication used. We saw no significant difference between the two groups in vasopressor use and in fluids used. This study has limitations. First of all, our results are only applicable to this specific patient group, entailing high-risk surgical patients. It was a single-center RCT with a small sample size powered on the primary endpoint, and we used a physiological rather than a purely clinical endpoint. And in this stage, that was necessary, so we chose hypertension. And I think this study is a really important stepping stone, but future studies should aim to assess whether this also actually leads to reduction in mortality and in morbidity, and whether it's cost effective. So to conclude, in this trial, we assessed whether we could use a machine learning derived early warning system to reduce hypertension, and we were able to do so without inducing overtreatment assessed by hypertension or dose of medication used. And future trials should assess whether this also leads to a decrease in complications and is cost effective. I would like to thank the HYPE study team, and I would like to thank you for your attention.
So we have time for a question.
Excellent presentation, phenomenal. We've been trying to do some work with our, waveform data from the arterial line, and one of the problems that we have is a lot of noise, whipping and clipping and things like that. Was that a problem with the trial, or does the device already have a way to sort of ensure the quality of the waveform so that the output is consistent? And
so do you mean you have problems with developing the algorithm, or with using it in clinical care?
the waveform data is not clean in the sense that there's a lot of artifact, movement artifact that will affect the quality of the waveform, and hence any data, any models that we build on the waveform has to take into account the quality of that data. Has that been an issue or not necessarily?
No, so for the development of the algorithm, that data was cut out because it's not good to build your algorithm on. And in clinical practice, we sometimes had that issue. So therefore, it's important there's a doctor to ensure the arterial waveform is of good quality.
Okay, thank you.
So our next manuscript, which will be published in Critical Care Medicine, is Data-Driven Analysis Reveals Shared Patterns in Transcriptome Responses and Immune Cell Compositions Associated with Distinct Mortality Rates Across Differing Etiologies of Critical Illness, and will be presented by Dr. Zador.
Thank you. Good afternoon. I'm Joel Zador, one of the fellows in neurosurgery at the University of Toronto. And today I'm going to talk about a conserved molecular signal that is shared across different etiologies of critical illness. And I'm going to present some initial evidence that this molecular signal can serve potentially as a universal marker of how patients respond to critical illness of due to various reasons, and also serve as a molecular endpoint for patients' resilience So the main motivation behind our study was the heterogeneity of diseases. So we sort of inherited this fairly old classification here from 1700s, and gradually over time, as we found out more and more about the diseases that we treat as doctors, including the molecular characteristics, mainly the molecular characteristics here derived from, for example, the Human Genome Project, completed in 2001, and it took a subtle 14 years for my field, neurosurgery, for example, to adopt it in the classification of brain tumors in the WHO grading. The second thing that really captured our imagination is the other broad impact of disease heterogeneity is that oftentimes it underlies why trials are negative. So this is a landmark example of the subphenotype that were identified from the reanalysis of the ARMA and the ALVA cohort. We're using a machine learning technique called latent class analysis. They have identified homogeneous subgroups, phenotype 1, that responded better to low PEEP, positive and expiratory pressure in acute respiratory distress syndrome, versus phenotype 2, where high PEEP was more beneficial. This study mainly included clinical parameters, and our interest homed down on the molecular aspects, the molecular response that patients mount to critical illness. And our research question was motivated by these two streams of studies, one by Zhao et al., who have identified a genomic storm, as they rightfully called it, this robust response that can be traced in the whole blood transcriptomics of patients suffering from critical illness of various kinds, and they've demonstrated that, for example, burns and trauma share a lot of the genes that are expressed in response to critical illness. The second line of studies that inspired us was that when you take the gene expression signal from patients suffering community-acquired pneumonia, there are homogeneous subgroups that can be identified with consensus clustering and another unsupervised machine learning algorithm. And consistently, there is a subgroup that displays the suppressed immune responses and is associated with poor outcome. So here's our the backbone of our research. On one end, we hypothesize that there's a molecular response that is conserved across etiologies of critical illness, represented by the space invaders over here. And then there's also evidence in the literature that patients mount a diverse response to that, and we hypothesize that unified response can be grouped into endotypes, homogeneous subgroups that share clinical outcome and can serve as a fundamental marker for patient resilience to illness of any description. So we carried out a meta-analysis of openly available data sets, mainly from the MARC consortium. I'd like to thank the authors for depositing this data. 382 patients with critical illness due to trauma, community-acquired pneumonia, and abdominal sepsis. And the analysis we carried out in a nutshell was a multi-step machine learning approach. On one arm, it was WGCNA-weighted co-expression network gene expression analysis. The crux of this multi-step technique is that we establish a network of gene co-expression, and based on how close they are, the individual genes to one another, they get grouped into this module down here, as depicted by this dendrogram on the left. And these modules are, the intuition is that they serve a unified biological process, which can be annotated through gene ontology. The second approach was a technique called cybersort, where from transcriptomics data we can infer various leukocyte fractions, which would normally be differentiated through using a number of molecular markers in clinical practice. So the first line of results showed we tested something that we already knew. We wanted to know whether gene expression patterns are preserved through trauma, community-acquired pneumonia, and abdominal sepsis. And firstly, we annotated the individual gene expression modules, and it's a fairly crude annotation. This will require some further refinement from our side, but immune response and, as expected, inflammation enriched in all the disease subclasses. And here, instead of comparing the individual genes on this heat map, we show the similarity measures that are derived from the closeness of relationship for each biological mechanism based on the gene ontology hierarchy. And as shown by the similarity measures, they are all very concordant. The more interesting line of results was the leukocyte composition of the individual disease groups. These heat maps summarize the frequency of each leukocyte fraction. Shown here in the columns, the rows are the individual patients, and on the left we have the dendrograms for the clusters that the patients can be grouped into, and there's a consistent pattern in trauma, community acquired pneumonia, and abdominal sepsis that there's a neutrophil surge and associated with the CD4 abundance in all three diagnoses, and the second element of the pattern is that there's always a neutrophil suppressed group with some suggestion of further mechanisms of immune suppression, such as the abundance of dendritic cells, T regulatory cells. When we label these consistent subgroups with mortality, we find that the neutrophil depleted group consistently has higher mortality rates, and in some groups the entire mortality is captured by the subgroup that has suppressed neutrophil counts. So we have the ability to go back and check what the molecular profile of these patient subgroups are. And returning to our gene co-expression modules, we've consistently found that the immune gene mechanisms, biological mechanisms that map onto immune response are consistently suppressed. So we have a group with a neutrophil surge and gene ontology mechanisms that map onto increased immune activity with better outcomes. And this holds the promise of the general universal marker that I was referring to explore what this truly means in terms of underlying biology. We would like to conduct a set of studies which is focused on the connectivity, the connectivity of these cellular fractions based on their co-expression with various interleukins. With this network-based approach, we can derive the biological activity of each cell fraction, as expressed here on these histograms, and ultimately explore the biological mechanisms that underlies these phenotypes. Another interest of ours is the concept of patient resilience. We've recently published this paper in Critical Care where multimorbidity configurations were studied using latent class analysis in 36,000 patients. From the MIMIC data set, we've essentially identified lethal combination of morbidity states, some of which were not immediately intuitive. So whereas we would expect increased mortality in the elderly and multimorbid over here, the highest mortality and the greatest susceptibility to sepsis was actually in more of a middle-aged group with liver disease, coagulopathy, essentially consequences of addiction. So this is really the dream where we want to get to create complex phenotypes that captures the baseline susceptibility of patients to disease, which would include categorical representation of multimorbidity states, gene expression data, imaging. There's an upgrade coming for the MIMIC data set that includes chest x-rays. We're eagerly waiting the release of that to carry out the study, and also some EHR parameters, vitals, and the pathogens that cause the illness. The technique we're proposing is a similarity network fusion, which is a local development in Toronto. Anna Goldenberg's group has pioneered this technique. A little bit about ourselves. We're a budding neuroscience data analytics group. Machine Intelligence Network Toronto, MINT is the name we've chosen. I'd like to thank the team for helping the work. Some of us are from a physics background, some of us are computer scientists, the rest are neurosurgeons, but I guess nobody's perfect. Thank you very much for your attention. I'm looking forward to questions.
So again, we have time for a question. So might I ask, do you think that these two different patterns are more related to the insult, that people are getting differential insults, or whether it's related to the patient's genotype?
Sorry, could you repeat that question again? There's so much.
So you've got, you showed two nice patterns, or two different patterns that were associated with outcomes. Do you think that the reason that people are having these two distinct transcriptomes are related to their underlying genotype, or do you think that they're related to differences in insults that cause differential responses?
Thank you. That's a very relevant question. I think the limitations of the molecular signal that we're capturing is that it is purely looking at the expression profile. So there's a lot of machinery that's superimposed upon that, such as epigenetics and other patient factors, which we're hoping to capture with that complex phenotype that I described.
Thank you. So our final manuscript in this session, before our next part of the session, will be simultaneously released in Critical Care Explorations, and we have Dr. Craig Lilly talking about vaping-associated respiratory distress syndromes, state-of-the-art and guidance for clinicians.
Thank you, Dr. Savansky. I've received no compensation as the chair of our vaping task force and have received nothing of commercial value from any entity involved in the sale of vaping-related marijuana or tobacco products. Today we're going to go over the exposure, symptoms, testing, risk stratification, and management of folks that have been exposed to vaping. This presentation and this review is not offered as a guideline. Unfortunately, the available evidence doesn't allow us to create an evidence-based guideline. It's simply provided as guidance to clinicians who are confronted with patients that may have vaping-associated lung disease. You can see from the variety of devices displayed here in this slide that there are a number of different generations, styles, and forms of vaping devices. So one of the things that we need to do when we judge vaping exposure is to try to determine what sort of a device is being used. You can see that the people that make international symbols have had a problem, because there's no one symbol that covers all devices. The currently available "you can't vape here" signs has 9 specific types of devices that it advises against use. All devices there are 3rd and 4th generation vaping devices. In terms of the device, the things you should really pay attention to are, does the device use cartridges that prepare a commercially available product and deliver aerosols of uniform or user-controlled size? Or does it contain a chamber where users can put in whatever solution they desire to put in there? And is the user using a solution that's commercially prepared and therefore free of dangerous adulterants? Or have they prepared their own solution using internet-obtained extraction protocols, often that contain vitamin E, terpenes, and other toxins? The key thing to exposure is dose, device, use, and the solution. So one of the key elements is, have they been exposed in the last 90 days? So the recency of exposure matters. The frequency is probably less important than the intensity. So are they a regular user that vapes according to manufacturers' recommendations, or do they get advice from social media? It turns out that by dabbing or dripping solution directly onto a heating element, one can generate a much denser, much larger volume of aerosolized particles per unit volume, and a much greater diversity of the size of particles. This allows larger particles to impact around areas of the lung where gas flow is turbulent and the airstream changes. And this leads to central airway deposition of both thermal energy as well as airway toxins. Particular risk factors are vitamin E containing or any member of the tocopherol family chemicals, and solutions that are prepared by non-commercial means. So after you've established whether or not your patient is vaping, and sometimes this is a challenge. In my intensive care unit, I noticed a really sleek-looking Juul device similar to the one here on this slide, and a patient that had told me she wasn't vaping. And I said, well, what's up with that? And she said, well, Dr. Lilly, old people vape, cool people Juuls. So part of getting the history comes down to understanding the language. The clinical evaluation really comes down to unexplained cough, chest pain, weight loss, fatigue, or dyspnea. This is part of the CDC case definition. The key thing is a clinical judgment about whether these are caused by vaping or caused by some other exposure. The key questions that are helpful are, was anyone else exposed to the vaping solution? Did you share your vaping device with anyone? Do they have similar symptoms? And is there anybody who's sick with this kind of illness who wasn't exposed to vaping? Those help you sort of triage cases that are likely to be vaping associated from those that are not. Another clue is whether or not there are GI symptoms. The same way that the aerosols can go down into the lungs, they also go into the GI tract. And when nausea, vomiting, or cramping abdominal pain is tightly associated with vaping exposure, one should assume that the patient's been toxin exposed. So what tests should we do? Well, there's really two types of tests. Some tests are looking for other causes. Electrocardiograms, workup for thromboembolic disease, and workup for infection should be considered, particularly to exclude and to help us determine whether the symptoms are toxic exposure or some other cause. If there's strong reason to believe that the association between the symptoms and the vaping is real, or if it's not possible to attribute them to another cause, one should do a rest and exercise oximetry and chest imaging. This allows us to perform risk stratification. One of the key things that our public health officials in Massachusetts came to us and asked us to do was to develop a risk stratification model that we call the Worcester model for doing this. It's very simple. If you just look in the top row of this particular table, if you're not exposed and you don't have symptoms, you don't have any risk, and you shouldn't be tested. If you've been exposed, but you don't have symptoms that are attributable to vaping, we recommend against testing, and we classify you as low risk. We recommend against testing at the time, and testing should symptoms that are associated with vaping occur in the future. Moderate risk patients have vaping exposure, and they have symptoms. They have an abnormal imaging study that has a pattern that's been associated with vaping, and these patients require special consideration. The highest risk patients, the patients at risk for death, and we've had one death in our community from this, have exposure, symptoms, an abnormal imaging study, and hypoxemia. Most patients that have died from vaping have been sent out of emergency rooms when they were noted to be hypoxemic. So our low-risk patients, what should we do about those? Should we do nothing? We think not. We think that every vaping patient should be advised to quit vaping. Secondarily, you should ask, have you tried to quit with the help of your primary care physician? When the patient's interested in quitting and they have not worked with someone in their healthcare team that they already trust, we suggest referral to their primary care physician for counseling. If they've been struggling with addiction and unable to quit and not able to partner with their primary care physician, we recommend referral to an addiction medicine specialist. For moderate risk patients, these are patients who have been exposed and do have symptoms that are potentially attributable. We think that vaping cessation is absolutely mandatory. So when you can supervise the fact that they will not be vaping, I think it's reasonable, we think it's reasonable to perform additional studies as an outpatient. The nuances of how to evaluate what subphenotype of vaping they have are present in our larger article and are beyond the scope of this talk. But the important thing is that for moderate risk patients, they need to be followed until their symptoms have resolved and their activity is returned to its baseline normal. For our high-risk group, we advise supervised vaping abstinence and continuous pulse oximetry. We believe the patient should be hospitalized. At the first sign of increased respiratory rate at rest, dyspnea at rest, hypoxemia at rest, oxygen therapy and early intervention with non-invasive ventilation is really important. It's probably more important than any other class of ARDS because these patients often rapidly improve when they abstain from further exposure. We recommend a conservative fluid strategy. We recommend corticosteroid therapy for any patient without rapid approval, who's not rapidly improving, and mechanical ventilation early when it's required with a low tidal volume strategy. We recommend that bronchoscopic evaluation be considered when infection, hypersensitivity pneumonitis, eosinophilic or lipoid pneumonia is suspected. We also share in our report a little bit about the airway phenotype of vaping. So it turns out that not infrequently vapors will have vaping tongue discoloration, just like this young woman here. This is from small particle aerosols. There's no burn here. Exactly the same coloration when it appears in a variegated pattern, and particularly if there's depression in the lesions, suggests that there has been thermal injury related to vaping to the upper airway. Those patients are at very high risk when you see that. Shahzad Khan and Kate Wadmunski Silva from our group have performed bronchoscopies on several of these patients and have noted that not surprisingly, the burns go all the way down the airway. Shahzad, in this particular example, noted that there were pseudomembranes that actually covered the segmental openings for the airway, and three-dimensional reconstruction of the airway demonstrated that distal to these occlusions there were radiographic infiltrates that cleared when he removed them. So we believe that the airway phenotype is caused by impaction and is an important sign of vaping-related injury. I'll simply conclude with this Gary Trudeau comic where Butsy and Jewel are talking against one another, and would encourage every intensivist when they leave their intensive care unit at night to ask, have I advised against vaping today? Thank you.
So we have time for a question.
Do you have any suggestions on the dose and the duration of the corticosteroids in patients with severe injury?
We prefer 1 milligram per kilogram per day. We usually give it twice a day. We use enteral steroids when it's possible and IV steroids when it's not. This is clearly expert opinion based. We feel that it's important to use enough steroid to have a therapeutic effect.
So prior to moving on to the next phase of the late breakers, I hope you'll join me in giving the 7 presenters a round of applause and thank them for sharing their work with us. So for the second part, and we will release the 7 speakers, we have the pleasure using some technology of welcoming Dr. Jiong Peng, who is chair and professor of critical care medicine at Zhongin Hospital and vice director of the Center for Clinical Trials at Wuhan University, who is going to present a videotaped version of a talk on 138 patients who've been infected with coronavirus COVID-19. And if the technology allows, perhaps he'll be able to answer some questions.
Hello, everyone. It's my great honor to be here to share my work with you. My topic today is 2019 novel coronavirus pneumonia in Wuhan, 138 case analysis from a single center. I'm Dr. Peng, intensivist from Wuhan University. The novel coronavirus pneumonia, which is called Ncp, is widespreading, highly contagious, and become public health emergency of international concern. This week demonstrates how this problem spread so fast within 20 days from one area to other areas. This also demonstrated the number on February 6th of the patients The confirmed case patients is around 28,000. The suspected cases is around 24,000. So I try to summarize the clinical features of the NCP patients from my current database and try to describe the disease process and the epidemiologic features and try to compare and analyze the differences of the patients in ICU and outside ICU. This is the retrospective cohort from a single center. All the patients enrolled from January 1st to January 28th. All the patients were confirmed using both of the criteria, including typical chest CT scan and the positive real-time RT-PCR assay. We collected the following data, including the demographic data, the underlying comorbidities, symptoms, signs, NAP, chest CT scan, treatments, including the medications, mechanical ventilation modes, and other organ supports. Results. This is the basic features of the NCP, including the age, gender, comorbidities. It was likely to affect old persons with comorbidities, and the patients in the ICU were relatively older and much more comorbidities than the patients outside ICU. This table demonstrated the symptoms and signs of NCP. The most common symptoms, including fever, fatigue, dry cough. Around 10% of the patients presented initially with diarrhea and subsequently developed fever and dyspnea. Dyspnea, abdominal pain, very frequently occurred in ICU patients. This is the clinical process of NCP. The time from the first symptom to dyspnea was 5 days, 7 days to hospital admission, 8 days to ARDS. The most common lab changes include the lymphopenia, prolonged prothrombin time, elevated lactate dehydrogenase. And the patients in the ICU were relatively lower lymphocyte counts and relatively higher lactate dehydrogenase compared to the patients outside the ICU. This is the dynamic changes of the lab test in some patients, including survivors and non-survivors. The survivors labeled with blue color demonstrated lower white count, lower neutrophil count, and higher lymphocyte count, lower D-dimer, lower urea, and lower creatinine. This is a very typical chest scan in one patient. A is the time in day 1. You can see the bilateral infiltration in this patient. B is the after 2 weeks treatment, the infiltration, the opacity become better compared to the A. This is the general features of the ICU patients. They have higher ABA2 score, higher SOFA score, and lower PFO ratio, around 136, very, very low. these patients in ICU always develop the organ injury. The most common organ injury and the complications including ARDS, cardiac surgery, arrhythmia, and cardiac injury, arrhythmia, and septic shock. Regarding ventilation support, only around 10% of the patients survived from the high-flow oxygen therapy, and 40% of the patients received non-invasive ventilation. About 50% of the patients needed invasive mechanical ventilation. 10% of them switched to ECMO. About the prognosis, on February 8, 40% of the patients still in hospital, 50% discharged, and 5.8% died. The hospital stayed around 10 days in survivors. Here, we also presented the updated information today on February 10. We took around 50 patients already in my ICU. Most of the patients right now much more severe because some transferred from other hospitals, and 60% of the patients needed invasive mechanical ventilation. 11 of them switched to ECMO. 4 went off ECMO already. Another issue about the transmission, you can see the figure, almost 40% of the patients transmitted in the hospital, including the medical care professionals and the hospitalized patients. About 70% of the infected healthcare workers from general ward, around 20% from ER, 5% from ICU. About the hospitalized patients, 40% infected in the surgery department, 30% from internal medicine, 30% from oncology. In conclusion, the transmission of the NCP was frequent, especially in the hospital. The untypical patients were probably the main source of the transmission. Critically ill patients tended to be older with comorbidities, specific symptoms, and lab abnormalities. The most common complication was ARDS, arrhythmia, and septic shock. Nearly half of the critically ill patients needed invasive ventilation. Thank you for your attention. Thank you for inviting me. Thank you for your support to my city, to my country, to my patients.
So I believe if the connection works, we may be able to have a question or two for Dr. Peng. After all the speakers, okay, in a few moments. So our next speaker, Dr. Ryan Maves, is going to talk about the 2019, or actually I guess the 2020 novel coronavirus, what we know so far.
Good afternoon, everyone, and I want to obviously thank Dr. Savransky and Dr. Pasquale and Dr. Howell and the remainder of the program committee and all of you for the opportunity to speak to you today. So I'm Ryan Maves. I'm an infectious disease and critical care physician in San Diego. I do work for the federal government. Just to point out that the opinions in this presentation are mine and do not reflect the policy of the U.S. government. I have no financial conflicts of interest. I will talk about some off-label and investigational drugs. So coronaviruses are a large family of zoonotic viruses spread to humans through some, usually mammalian intermediate, very often bats. So human coronaviruses, there are 7, including the new novel one, which probably comes at us from a bat, most likely. It's part of a group called beta coronaviruses, which also includes the other 6 human infections, the 4 usual human coronaviruses, which cause a relatively mild respiratory infection in most patients, SARS, MERS, and now this novel one. Very recently, the International Commission on Taxonomy in Viruses has decided to name this Sars Coronavirus 2, due to a high degree of homology with the previous SARS coronavirus from 2003-2004. There's a little bit of controversy about that, but right now NIAID is using that name on its website. So this virus is 79.5% homologous with SARS-CoV, with the original SARS, and is 96% identical at the whole genome level to a previously identified bat coronavirus. Its target in the human respiratory tract appears to be angiotensin-converting enzyme 2, which is similar to the older SARS-CoV, and is presumably, although not yet 100% certain, to be the root of infection. It's a pretty typical-looking coronavirus, 4 structural proteins and a single-strand positive RNA genome there in the middle. All right, so I updated this morning, and I have to say this is interesting for a talk in that it is almost certainly out of date by the time I give it. But there are approximately 72,000 cases reported to WHO. This is the Johns Hopkins CSSE website that tracks this on an ongoing basis. So about 72,000 cases, 1,775 deaths reported so far. Overwhelmingly, these are in Hubei province in China. Handful of cases in the United States, 15, possibly going up, and a variety of cases in the remainder of Asia, Europe, elsewhere in North America. So far, not quite 12,000 people are reported as recovered, so a number of these people remain hospitalized or remain ill. So early on, cases were linked to the wholesale seafood market in Wuhan. There were some attempts to assess whether or not this was due to animal exposure in the market, but it turns out there were a number of cases that didn't have an epidemiologic link to the market that occurred very early on. It is possible that the market, which is a crowded aggregate setting, could have been an amplification for the outbreak, where someone who was infected entered the market and then transmitted it within the market, leading to the outbreak within the city. That remains unproven, but if you look at one of the early Lancet series here, blue are the non-market associated cases, red are market associated cases. And you see that these blue cases occur pretty early. So again, the market may not be the source, but rather a source of amplification. All right, so transition dynamics. We're still learning how this virus is transmitted in nature. So in general, coronaviruses and other respiratory viruses have about a 2-meter range. That is, if you're coughing on someone, the zone of maximum danger is about 2 meters. It's like when you're on an airplane, how many rows do you have to be away from someone with influenza before you're at lower risk? Other coronaviruses persist in the environment in sort of room temperature, low humidity conditions for up to 4 days. What the implications of that are going to be for this virus and for infection prevention with hospitals is still being determined. Another topic you probably have seen in the news, this idea of the R0, that is the number of secondary cases that arise from a primary infection. So the estimated R0 for this novel coronavirus is somewhere between 1.5 to 3. That's still being sorted out. And that can change over time as changes in a population in terms of immunity and exposure evolve. So for example, H1N1 influenza had an R0 of about 1.5. Measles in an immunologically naive population is an R0 of 12 to 18. So very, very contagious. The original SARS from 2003-2004 had an R0 initially about 3.5, but as environmental and policy controls were put into place, that declined very rapidly down to 0.7. And that's part of why that epidemic did not propagate further. All right, so there are a couple practical things for critical care professionals to know about. One is, how do we identify what we call a person under investigation or person of interest who is at risk for having this infection, having COVID-19, and determining whether they need further workup. So there's kind of a sliding scale of severity and epidemiologic risk that will determine the risk. So the highest risk category is going to be someone who has been exposed to a confirmed coronavirus case or has had a laboratory exposure to the virus itself. Those people can have fever or signs and symptoms of a lower respiratory tract infection. That would then be sufficient to put them into being a person of interest who would require further evaluation for disease. And someone who has traveled to Hubei province in China within the last 14 days, the case definition is fever and signs and symptoms of a lower respiratory tract illness. And then in someone who's been simply to mainland China within the last 14 days, it's fevers, signs, symptoms of a lower respiratory tract illness, and illness severity requiring hospitalization. So the scrutiny goes up, the less firm the epidemiologic risk is. And this is continuously updated at CDC, and this may potentially evolve over time as our understanding of the epidemiologic risk factors and as the nature of this outbreak evolve. So CDC also has a flow sheet, and Dr. Evans will go over this in greater detail, but I think it's important enough to take more than one look at. And this is something practical for application in the hospital, and this is again available on the CDC website. So a patient who has had travel to China or close contact with someone with a known case of COVID and has fever or signs of a lower respiratory tract infection, that's a person who we should at least consider this is a possibility, with further assessment of the risks and the institution of some initial basic infection control measures that, again, my colleague will discuss in greater detail. All right, so this is Dr. Peng's paper, and again, with nothing but gratitude for him for the work that he's doing, taking care of hundreds upon hundreds of patients in his home city. But just to reiterate the key points of his paper, 26% of his admissions required placement in the intensive care unit, and there was a median time of 10 days between onset of symptoms and development of severe disease requiring ICU admission, with 60% of them having ARDS, half of them requiring mechanical ventilation, and a large and a substantial amount of patients requiring ECMO and or vasopressors. So their overall mortality was 4.3%, but a lot of their patients remained admitted at the time of that publication. And markers of severe disease and risk of death included lymphopenia and neutropenia, that the non-survivors had sustained neutropenia and lymphopenia, whereas survivors tended to have recovery of their cell lines earlier on. But that 10-day period is important, right? Because I think that may inform what we do for treatment. If this is a late, for example, immunologic complication, that could affect timing of antiviral therapy, much like neuraminidase inhibitors in influenza, where their efficacy is greatest the earlier you start them in relationship to their symptoms. So diagnostics. So if you look at the report on the multiplex PCR in your hospital, there will be a line that will say coronavirus. That test does not detect this virus, right? That detects the 4 conventional human coronaviruses. It doesn't detect SARS, it doesn't detect MERS, and it doesn't detect this. So all diagnostics have to be done in coordination with your local public health authorities. In the United States, that would be your county public health department or analogous organizations in your home of origin. Testing until very recently was done entirely at CDC. That led to some time delays because of bottlenecks. That is now improving as other laboratories around the country have access to the primers and probes and can perform this closer. But again, all of that does need to be coordinated with county public health. So when we identify those PUIs that we described before, the next step is to call, after taking care of the patient, calling the county and finding out, is this person suitable for screening? Should I be sending assays off to one of these reference laboratories? All right, so clinical care. There's not a lot to say about clinical care yet, and certainly nothing that I could add to Dr. Peng's presentation. Care is principally supportive, and staff safety, when you saw those high numbers of healthcare workers infected, staff safety is always going to be at the top of the list, right next to care of the patient and safety of the patient. So potential interventions that are under at least consideration. Glucocorticoids are used in a large proportion of the cases in China and in Japan. They are not presently recommended for SARS or MERS. Whether they will have a role in this disease, I think, remains to be proven. Certainly, if someone has another indication for glucocorticoids like vasopressor resistant shock, that would be another story. Bacterial co-infection is reported in about 10% of patients, and there may be a role for empiric antibacterial drugs. Investigational therapies, the one that's gotten the most press is remdesivir, which is a viral RNA polymerase inhibitor under evaluation by Gilead. This is available as an investigation, as an emergency IND, but use of this drug should generally be done in coordination with a registry, such as the MEURI framework for the use of investigational emergency agents, so that we're getting good data and can have an idea of what is the actual use of these drugs. There are a number of randomized trials that are in development and moving towards approval very rapidly, and if you look in clinicaltrials.gov, there are 50 RCTs right now for novel coronavirus and an equivalently large number on the WHO website. There is some interest in Asia looking at lopinavir-ritonavir, which is an older antiretroviral drug. Whether that has any benefit remains to be proven. Another thing just to make a push for is the idea of standardized data collection. One of the challenges in other epidemics was difficulty with comparing different case series. We'd have cohorts out of multiple different institutions around the world, and comparing those cohorts in an organized manner was difficult. So within the Society of Critical Care Medicine, the Resilience Intelligence Network, under the leadership of Dr. Perrin Cobb and a number of people in this room, is looking to develop networks to permit the standardized data collection in public health emergencies. Internationally and under WHO auspices, there's an organization called ISARIC, the International Severe Acute Respiratory Infection Consortium, which has a standardized protocol with standardized case report forms that you can download off the internet and are available to use only requiring attribution. And that sort of thing will help us make our data easily interpretable between each other. And then there's other comparable protocols in development. So just for a little bit of perspective, obviously this is a public health emergency. Right now, as of this morning, about 72,000 cases of COVID in the world, about a little more than 1,700 deaths. Each one of those deaths a tragedy. In the United States, in a typical influenza season, there are 30 million cases of influenza, and there are 30,000 deaths. So while this mortality is troublesome, we should remember that this is flu season, remember to look out for influenza, remember to take standard precautions for other comparable respiratory diseases, right? So in summary, this is a dynamic and rapidly evolving outbreak, and the direction this is going to take in terms of our hospitals and in terms of global public health remains to be determined. Current case fatality rate, 2 to 3%. The impact of mild or subclinical disease is unknown. There are going to be a number of undiagnosed cases, and how that'll affect the case fatality rates unknown. Care is primarily supportive. There are some investigational therapies that will be under study. Priorities for us in our hospitals: early detection, infection prevention, staff safety, and obviously taking care of sick people. Thank you very much for the opportunity, and we'll be available for questions afterwards. Thank you very much.
So again, at the end of this second half of the session, there'll be time for questions, I hope, with Dr. Pang available. Our next speaker is Dr. Laura Evans, who will be talking about preparing for COVID-19.
Great. Thanks, John, and thanks to SCCM and all of you for the opportunity to be here. I'd also like to take the opportunity in the moment to thank Dr. Pang and all his colleagues in Wuhan and in Hubei province for the incredible work that they've done, as well for sharing all of that information for us so that we can help to prepare as this virus potentially spreads to our communities. So with that, this is not a research presentation. I'm going to take a step back and try and be really practical with some guidance about what steps we might be able to take now. And I think I'll echo a lot of points that Ryan may have just made in terms of the central nature here of really, really tight adherence to infection prevention and control is the root of how we're going to approach this. I don't have any financial conflicts to disclose. I do get some salary support from the National Ebola and other emerging diseases Education and Training Center, which is funded by HHS, ASPR, and CDC. So these numbers need to be updated after today. This is as of before the weekend, actually, where we had 15 positive cases in the United States, just to put that in perspective of what we're looking at in terms of global numbers, and a total of 443 persons under investigation in the United States. Those numbers have clearly changed now with the repatriation of American citizens, particularly from the cruise ships around Japan. So those numbers will be updated later tonight. I wanted to start with kind of the take-home messages, in fact, which is, I think, the keys to how we're going to prepare here. And that is really a central focus on some of the ideas that Ryan already brought to bear in terms of early identification, prompt isolation of persons under investigation, and then activating systems to inform public health colleagues and our colleagues in infection prevention and control to mitigate the spread to other patients or to healthcare staff within our institutions. I want to talk briefly about the hierarchies of control with a focus a little bit on PPE, but recognizing that PPE is not the central way that we control spread of infection. Tight adherence to infection prevention and controls, how to use PPE, resources that are available to you. So the first thing I want to call your attention to is what's posted online at the CDC, which is a hospital preparedness checklist. And this is more geared towards institutional preparation, but I think us as individuals also can take points from this home in terms of helping our institutions prepare, but also helping our units and our cells become ready to deal with any emerging pathogen. This is clearly not COVID-19 specific. This applies to any situation, and as Ryan already mentioned as well, you can use many of these for responding to seasonal influenza as well, which clearly has a major impact on us every year. So we need to know what our procedures are for rapidly identifying and isolating persons. We need to make sure that we know where our airborne isolation infection rooms are and if they're functioning, so developing a close relationship with our facilities management folks. We need to understand what we have in terms of PPE availability, supply chain, and begin to develop some contingency plans for what PPE might look like in shortage of supply. We need to think about what our surge capacity procedures might look like for not just a single individual patient with COVID-19, but rather a small cluster of patients, a family, or even a potential surge of a larger number of patients. Where would your overflow areas be? How would you apply environmental infection control in those situations? And review procedures for how we would get specimens to the lab, particularly since the diagnostic testing, as we already learned, is done in the regional public health labs or at the CDC. So these are not testing, confirmatory testing for COVID-19 cannot be done at the hospital level at this time in the US. And then we need to assess the effectiveness of environmental cleaning procedures. Some more highlights from this checklist include ensuring that our healthcare staff has been medically cleared and fit tested and knows how to safely use an N95 respirator. Now is a great time to provide education, refresher training to our staff regarding the diagnostics, some of the clinical information as we're learning how this disease behaves and evolves, how to get specimens, what specimens are necessary for testing, how to appropriately use PPE, and where these patients would go within our hospitals. And then critically around this, we also need to log who's involved in the care of these patients so that we can enroll them in symptom monitoring programs as needed. It's also really important to think at now how you would approach visitors for patients with COVID-19 in your institution. What kind of restrictions might you impose upon visitors in that setting? We saw this, I broke this down. This is sort of the first critical step. If you think about where our vulnerabilities are in the healthcare system, it's predominantly most likely to be before these patients are identified as having COVID-19 or seasonal influenza, or any other readily transmissible pathogen. So facilitating processes to make sure that we can identify these patients promptly is clearly our first and probably our best line of defense. And this is directly from the CDC, again, in terms of the schematic that they represent for COVID-19. I would actually recommend that perhaps we've sort of flipped the script here. And because the CDC algorithm starts with travel first, and we just have to remember back to Ryan's slides about the impact of seasonal influenza and think perhaps what we should be doing at sites of entry is not talking about travel as the first question, but rather fever or symptoms of lower respiratory illness as the first question. And use that as the opportunity to implement risk mitigation at that stage. So anybody with a fever, cough, respiratory symptoms should be given a mask to try to control transmission within our facilities, sort of regardless of diagnosis. That also gives us the time then to safely pursue questions about travel. And these are just some examples from different medical centers and different systems around the US in terms of signage that can help folks to identify patients early. And you can see, at least at the Emory system here, John is probably quite familiar with this, is that it starts with fever and face mask, and then it proceeds to travel. And I think that's a really good way to approach this in general from an infection prevention and control standpoint. So if I identify somebody who has some epidemiologic risk, that doesn't mean they're a person under investigation. It means they have some epidemiologic risk and some symptoms. I'm going to put that person in an isolation environment so that I can take the time then to ask further questions and determine if they may meet the case definition to be a person under investigation. So I need to have that area identified where I'm going to put that person. I'm going to then proceed with my evaluation wearing appropriate PPE, and we'll talk about what that might look like. Following those additional questions, and your individual hospital procedures may vary as to what point you involve your local infection prevention and control team. But following that, if you think a person meets the case definition, you're clearly going to activate notification of your local public health jurisdiction and decide if testing for COVID-19 is indicated. We saw this already. I just want to bring it home that these criteria may change over time. They've already changed in the last few weeks as the outbreak has spread from Wuhan City to Hubei province in a larger sense, and then to other areas within mainland China. So keep your eye on these sites on the CDC, because the definitions of the case definitions of PUI are likely to evolve as if we develop significant community-based transmissions in sites outside of mainland China. Hierarchy of controls, some of you may or may not be familiar with. This is a sort of a NIOSH pyramid for this that describes how we can mitigate risk from it. And many of these don't readily apply to us in the healthcare setting, but they're, I think, a good construct for us to think through how we can help protect patients and ourselves from that. And I'll call your attention that PPE is down at the bottom here. So it's not the first thing we do in terms of mitigating risk. We want to think of, can we eliminate the risk? Can we substitute it? But I think when we're talking about healthcare, we're really talking about these three triangles down at the bottom. Engineering controls, so that would be examples of our airborne isolation rooms. Administrative controls, so having safe work practices already in place with people properly trained, knowing who's going to go in the room and making sure that untrained personnel do not enter the room. And then using PPE, of course, as an additional supplement. Where we are with PPE guidance right now is we're seeing a lot of different images come across, certainly media, as to what people are wearing for PPE. CDC PPE guidance is quite clear, and they have some baseline language about that we should be receiving training and demonstrate how to use it, what PPE is necessary, and most pertinently, I think, how to properly don and doff PPE to prevent contaminating ourselves during that process. What the limitations may be are as well. Clearly, PPE that's reused needs to be properly disinfected before reuse. And we should all have policies and procedures in place to ensure that we have safe practices for that. Current CDC guidance is gloves, a standard disposable isolation gown, a fit-tested N95 respirator or equivalent, and eye protection in the form of a face shield or equivalent. That can be goggles, that can be, for example, I just have a standard face shield here. So that is, and when you think back to what Ryan just told us about what is known about the mode of transmission, that this appears to be droplet-based transmission, this is appropriate PPE based on that. So this is current CDC guidance for that. CDC also offers some guidance on proper donning and doffing, and I would encourage you to review that. I would also encourage you, if you want a video of it, if you're more of a visual learner, NETAC, the National Ebola Training and Education Center, has produced a PPE donning and doffing video here. It's available free on YouTube. So if you search YouTube for NETAC COVID-19 PPE, it'll give you a video for how to don and doff this recommended CDC PPE for COVID-19, as well as, I think, take you through some of the safe behaviors in PPE. From that, you'll notice everything starts and ends with hand hygiene, which should be our normal practice anyway in the ICU. Aerosol generating procedures, I think, provoke a certain degree of anxiety in people when we think about respiratory transmitted pathogens. And so the guidance is to basically be cautious about this. And if you're doing something like bag valve mask ventilating a patient, intubating them, delivering nebulizers, inducing sputum, I think there's an unanswered question about the use of non-invasive ventilation in this patient population and what that may do in terms of infection control. But there are certain things that you can do to mitigate that. You can put HEPA filters on the expired air limb. You can do that to a bag valve mask ventilator. You can obviously do that on a standard mechanical ventilator. If you're performing procedures like this, they should take place in an airborne isolation room, and you should limit the number of personnel to only those numbers that are absolutely necessary to do that. And obviously the personnel who are doing that should be trained in proper PPE. I want to spend just the last couple minutes sort of drilling down on some of this because it's not, people focus a lot on PPE talking about equipment, and it's not just about equipment and supplies. It's about how we use them and how we behave in them. So I really want to drill down on this, and we'll kind of go around this clockwise here. So the way we behave in PPE is one of the central elements of how we keep ourselves and our colleagues safe and our other patients safe. So reducing the environmental bioburden. So trying to keep the room environment clean. We don't know exactly how long this virus may persist in the environment. So using things like while we're in the room, taking the opportunity to disinfect and wipe down high-touch surfaces may mitigate the environmental bioburden. Trying to keep our PPE relatively clean. If I'm doffing cleaner PPE, I'm less likely to contaminate myself during the doffing process than if I'm doffing PPE that's grossly soiled. Obviously, don't touch your skin, your hair, your eyewear. We see a lot of reach up under the face mask to adjust your N95. That's a big no-no. Again, use additional barriers when you're going into an area that you think may be highly contaminated or doing something that you think may result in gross contamination of your PPE. Know what your breach protocols may be. Don't hesitate to clean and disinfect or change your gloves. You can use alcohol-based hand rub on exam gloves to disinfect them. You can do that. You can also change them during that. Be aware of your condition. Don't get yourself into trouble. So if you're having trouble with an N95, feeling hot, feeling excessively sweaty, that's the time to call for help and get out of that room so that you don't have to be extricated from that. If you're using a trained observer, which is not required by CDC in this situation, if you opt to use a trained observer, and follow the instructions from your trained observer. And then obviously check your PPE for contamination before doffing. So to summarize again, the situation's rapidly evolving. There's, I think, very substantial uncertainty about what the impact may look like in terms of, we think that Ryan gave us some great information about current data about case fatality ratios, but I think we also know that if we're in the United States, if we experience a significant influx of seriously ill patients, that will put stress and strain on our healthcare delivery system. None of us have tons of extra capacity in our emergency departments, inpatient units, or ICUs, and I think we need to be prepared for that. We need to know what our process is for identify, isolate, and inform, and we need to be testing that now. Now is also the time to review and train on the proper use of PPE. This is the window of opportunity to do that. It's a good idea to do in general, and this is a great opportunity to do that. We talked a little bit already about preparing to make sure that we have the capacity to collect clinical data. And I think that's one of the things that Dr. Peng illustrated to us really nicely, is that his ability to collect and report clinical data has informed us. And so we need to be able to do that as well. And Ryan gave us some resources to do that in terms of there are already pre-prepared case report forms. You can submit and get those through your IRB now, so that if you start getting patients with COVID-19, you can start pulling data on those patients. And again, the keys to preparedness across any event is always communication, collaboration, and coordination. And I will stop there by just putting some resources up there. This CDC website, of course, the WHO website. This Johns Hopkins Center for Health Security is publishing a fantastic daily newspaper. We have some neat resources on the NETEC repository, and then WHO just released an update to their severe acute respiratory infection course, which is a fairly lengthy online course. It has about 12 modules, takes about 10 hours to complete. It's more geared towards low and middle income countries, but I think still a great resource for us, and I'll stop there.
So while it's at 5:15, we do have this room for a little bit longer, and we have both Dr. Maves and Dr. Evans to answer questions. Unfortunately, we had a technological kerfluffle with Dr. Peng, and he will not be available for answering questions.
This is for Dr. Maves, Tim Buckman. You mentioned that there is a significant, or at least 10% estimate of superinfection with this viral pneumonia. Is that a low estimate, a high estimate? And the reason I ask is that in the data that Dr. Peng showed,
right,
it appeared that there, among the survivors, there was actually a significant rise in the total white blood count. That is, there was a significant neutrophil leukocytosis. Would you comment?
So actually in Dr. Peng's series, it was less than 10%. He isolated a handful of cases of Acinetobacter and some likely commensal yeast. So his experience is less than that. The 10% comes from some other series, and those are among hospitalized patients, not from the full 77,000 or 72,000, I'm sorry, number of cases. So whether a post-viral bacterial pneumonia is a major part of the immunopathogenesis of this, I think is completely unknown, and that 10% is entirely speculative off of a few small series. Again, Dr. Peng's experience doesn't reflect that, and I think it is premature to say at this point. But it's a great question, and that's one of the, like flu and metapneumovirus would be two major comparably severe viruses that would have a similar syndrome. Wow, easy crowd.
Thanks very much. Very timely and informative. Any information about the effect in children?
I think we don't know. Certainly the number of cases reported in children appears to be low. We have to remember that the case definition that was publicly reported has changed in recent days, and previously it was a laboratory confirmed diagnosis. And so you wonder about underreporting of milder disease. So if the clinical disease is milder in children than in adults, they may not have been tested. I think we'll have to keep an eye on that now that there's also a clinical definition for case reporting, particularly from Hubei province, to see how that changes. But I think we don't know. There does appear to be different signal in children rather than adults. Do you want anything?
Oh, no, that was great.
Jeff Bellingham, two questions. First one is if you could comment on the story where some patients test negative potentially over a number of times and then positive. And the second one is the choice of 14 days and some of the stories suggesting that might be out to 20 or 24 days before you can move from being asymptomatic to symptomatic.
In regards to the negative testing, there was, this was reported in the media in my home city in San Diego, cases of initially negative PUIs who were later found to be positive. That appeared to be the result of an administrative issue rather than a technical issue. Certainly goes to reinforce the importance of administrative controls in addition to technical controls. But any test has sensitivity and specificity, even anything as remarkably sensitive as PCR. In terms of the 14 days, it seems that the median time between exposure and clinical symptoms is about 5 to 6 days. So the 14 days is actually at the longer end. I think there will certainly be handfuls of patients who shed for more prolonged periods of time or have a longer period. Like anything, it's a bell-shaped curve, and there's going to be a tail at the other end. But I think with the 14-day period, that's keeping us within a few confidence intervals of the great majority of cases, at least as described thus far.
When I read, like in the news about the cardiovascular complication, that there is a specific predilection of the virus to coronary arteries. So what are the clinical implications? Do we expect like STEMIs, cardiac ischemia, and what are the treatment implications?
So I don't think we have an honest answer for you about that, sir. I will say that influenza is also clearly associated with myocardial infarction and myocarditis as well. It's called hemagglutinin for a reason. It's a prothrombotic state. Whether that is also true of this coronavirus, I think, is unknown.
I think I heard you say that there's about 80% genetic identity with the previous SARS or SARS type 1.
Correct, sir.
For which there was a vaccine developed, I understand, but was never used.
Right.
Is there any thought that that old vaccine would be potentially effective against this new virus?
So kind of a two-part answer. So sort of a two-part answer. So number one is I am certain folks are thinking about that. I'm not directly involved in that, and I can't speculate. I can say, and this is in the press, that Dr. Fauci at NIAID anticipates having phase 1 human trials of an investigational vaccine, likely using, and I'll ask Dr. Evans to correct me if I'm wrong, the RNA the RNA vaccine platform that they've developed and tested for Zika and some arboviruses previously. So that should be, hopefully, in the next few months. In terms of cross-immunity, there is some interesting literature on the effects of cross-immunity between different coronaviruses. There doesn't appear to be cross-immunity between, say, like the other 4 routine human coronaviruses, right? So I don't think we would necessarily anticipate that in this case. And there is this interesting signal from animal coronaviruses that secondary infections may actually be more severe, kind of analogous to dengue. So I would be hesitant to assume that an existing SARS vaccine would be useful in this case, although it certainly does provide a model that vaccine development could use going forward for developing a specific vaccine.
So please join me in thanking Dr. Maves and Dr. Evans for their timely presentation.
And Dr. Peng. And you.
And we'd like to thank Dr. Peng in absentia for his wonderful summary, and thank all of you for sticking around well past the 2-hour mark. Have a fine afternoon.